Now we're going to come back to FOLFOX versus FOLFIRI, and is there anything that can help enrich, what kind of regimens to use, but we'll come back. Let's talk neoadjuvant just a second. What do you see in a patient who's resectable right now, synchronous, that patient I just told you, resectable right now, 3 lesions, let's make them all on the right, primary in place, showed up 52, the patient says, get it out of me. What are you going to tell them?
So it depends on how big those lesions are in the liver.
No, 1 centimeter.
Oh, all 3 1 centimeter?
3 1 centimeter things. PET positive.
Well, in that
surgery
setting,
first?
Sometimes we do surgery first.
Combined surgery.
And how do you make up your mind, you people?
Well, once again, in all fairness, I talk to my surgeons.
Surgeon?
Sometimes
if they're going on vacation soon or not?
Sometimes they mark the area, they mark the lesion.
Because it may go away.
Yeah.
It may go away completely. That's why I'm a bit hesitant if it's only 1 centimeter.
Well, so I guess a lot of us have said, well, we like to see the biological impact of that. We get to test the cancer.
Because it's likely you're going to give them adjuvant chemotherapy afterwards.
And there's some studies that said if you responded, you did better, right? So, but prognostically, that it was sort of a predictor. Does it guide you in an adjuvant set, post-operative setting, if you've given pre-op?
I think this is an area everyone has their own little niche.
So what's yours? What are you doing?
So depends how much I gave beforehand.
Okay.
I usually always give something. It could be just from Xeloda alone to maybe sometimes FOLFOX. And what I have to remind people is you do not give FOLFIRI if everything is resected. Sometimes people will do that.
Is the Norling-J study positive or negative?
Negative.
Negative? This is the FOLFOX before and after resection. Is 8% PFS at 3 years and
it's a negative study by
with
all
a positive
measures.
conclusion.
with a positive conclusion.
It's a
spite of the
negative study,
negativity,
and
this was a
actually
positive
that
study.
study is one of the main reasons why I probably am reluctant for a patient who's straightforward or surgical candidate to even give chemotherapy.
Just
go to surgery. I don't even, for many of those patients, if they're metachronous single lesion or a couple lesions, I don't even give them chemotherapy after surgery.
It's really hard not to give that patient
Well,
chemo,
I find
though,
it
right?
actually very easy.
Well, no,
after discussion.
you must not be on an RVU metric.
An important part of that
Not
study.
anymore.
An important part of that study is whenever you have a baseline good result, it's hard to show an improvement, like with stage 2 colon. So in that study, they had to have 1 to 3 resectable lesions, and 50% only had a solitary lesion. So they did so well, you couldn't show a benefit.
I agree with you on that.
And
Because
that's
there's
the
probably
problem.
no benefit in that group of patients.
Correct.
Correct.
Yeah.
I think the
It
main
was a very
point,
select patient population.
main point I want to make is that I don't know what to do with the stage 4 no evidence of disease patient. I mean, am I giving adjuvant therapy? How much do I give? And what drugs do I give? Is it biologics or not? Pre versus post. And you make a decision based on your gut feeling and your multidisciplinary tumor board and the surgeon's vacation time, right? I mean, let's be honest, that's true. We don't have, is anybody got science that they can put in here other than a feel and experience?
It's experience.
Experience.
I think if someone has a solitary lesion or 2 lesions and they're 4 years out and they had a stage 2 tumor to begin with not 15 positive nodes, with a lesser likelihood of extrahepatic metastases, I wouldn't do anything.
Okay.
If they had stage 3 disease, N2, 5 lesions in the liver, there are no data on it,
Yeah,
but I would probably give them the post-operative therapy.
Give them
And,
some chemotherapy.
and that's a different disease. That I agree. That's
biology
a
is
different disease. That's probably a stage 4, a true bona fide stage 4 with more wide metastatic disease.
And we've stopped doing this, I think, for the most part, but let's say stage 3 adjuvant got FOLFOX, a year and a half later, liver met, resected. We're not doing FOLFIRI, or are we? For the heck of it? What the heck?
No.
No? No? Maybe neoadjuvant, but not
Maybe,
just,
yeah.
not adjuvant
Not adjuvant.
FOLFIRI.
No,
Okay, just
definitely
want to
not.
make sure.
Depending on your intent.
Yeah,
Exactly. So
yeah.
neoadjuvant is different intent than adjuvant.
Are you treating metastatic? Are you treating adjuvant?
Absolutely.
But I think
There was actually a negative post-operative trial of 5FU versus FOLFIRI from
The
the
ECHO
French
study.
group. It was small, but it was dead negative.
But
in
no
fact.
signal.
Yes.
right?
No signal.
But I
Tony,
think
oh, sorry.
it's really important to emphasize that there's not enough trials really to look at the liver resection patient population.
And it's so hard to study. I mean, because you've got patients with 5 liver lesions and 14 positive nodes who would be eligible, plus that one isolated liver wedged off, and they're very different people when you can't really squeeze them into the same. So we clearly something we need to study.